Welcome! Today, we will demonstrate the complete 10 step-by-step procedure of blood donor screening and blood collection. The primary goal of blood banking is to provide the safe and efficacious blood components for transfusion to ensure both the safety of the donor and the recipient, and every donation must strictly follow a systematic screening, collection, and testing protocol. Let us walk through the introduction steps, which will involve the following: donor registration, donor interview and history taking, physical examination and vital signs assessment, hemoglobin hematocrit screening, blood typing and required screening tests, blood collection procedures, and lastly, post-donation care and instructions. The first major step is donor registration.
The primary goal is to establish a definitive identity for the donor and link them to any past donation records or deferral list in your database. To verify identity, you must collect an official photographic identification like a driver's license or passport. Next, you are required to provide the donor with educational materials. These documents clearly outline the risk of relevant transfusion-transmitted infections, specifically detailing the signs, symptoms, and high-risk behaviors associated with HIV and AIDS. Providing this education before the formal interview allows individuals who recognize they have engaged in high-risk behavior to safely and discreetly self-defer, walking away without having to answer uncomfortable questions. Once they have read the materials, the donor must sign a written informed consent. This is a legal and ethical mandate, confirming they understand the risk of the procedure and their own responsibility in maintaining a clean blood supply.
Step 2 is the health history interview.
Because you will be asking about sensitive high-risk behaviors, this interview must always be conducted in a secluded, private environment to ensure the donor feels safe providing honest answers. This document shows the blood donor history questionnaire used by Sultan Kudarat Provincial Hospital. The questionnaire gathers information about the donor's present health, recent medications, vaccinations, and possible exposure to infectious diseases to determine if blood donation is safe for both the donor and the recipient. Based on their answers, a donor might receive a temporary deferral. For example, if they recently traveled to a malaria endemic area, they will be asked to wait a specific number of months before they are eligible to donate again. Other answers result in an indefinite or permanent deferral. A history of viral hepatitis after the donor's 11th birthday, for instance, immediately and permanently disqualifies them from ever donating blood for someone else. Because certain pathogens cannot be detected by laboratory testing during their inhibition periods, this questionnaire acts as an essential epidemiological filter, relying entirely on the privacy and honesty you cultivate with the donor.
Once the questionnaire is passed, we proceed to the physical examination and vital signs.
This is your clinical checkpoint to confirm the donor's body can safely handle the sudden loss of 450 to 500 milliliters of blood. On our dashboard, weight must be at least 110 pounds, temperature cannot exceed 37.5 degrees Celsius, pulse must be between 50 and 100, systolic pressure must be 90 to 180, diastolic 50 to 100, partial pressure oxygen should be 94 to 100%. With the vitals recorded, visually inspect the antecubital fossa on both arms. As seen here, you're looking for a suitable target like a median cubital vein, while simultaneously checking for skin lesions or track marks that indicate illicit intravenous drug use. When a healthy donor passes these psychological thresholds, you can be confident the collection process will not induce shock or cause them physiological harm.
Before we can collect blood, we must perform a hemoglobin hematocrit screening.
Before beginning the draw, a capillary stick is performed to measure the hemoglobin content of the donor's blood. In the copper sulfate method, a blood drop is centimeter above a 1.053 specific gravity solution. If the drop sinks within 15 seconds, the donor passes. If it remains buoyant or break apart, the specific gravity is too low. To qualify for allogenic donation, female donors require a minimum hemoglobin of 12.5 grams per deciliter, while male donors must reach 13.0 grams. This thus confirms the donor has enough red cell mass to survive 150 milliliter loss without experiencing immediate physiological distress.
Though the actual donor testing occurs after collection in the laboratory, it is mandatory and a part of the screening process before blood collection to screen for the donor's blood types through a slide method.
This is a quick pre-collection screening tool to find out the donor's ABO and RH group, though it does not replace the formal confirmatory tube testing performed later in the main laboratory. In this macro view, we begin by placing 3 distinct drops of commercial anti-sera, anti-A, anti-B, and anti-D onto a clean glass slide. Next, you add a small drop of the donor's whole blood next to each drop of the anti-sera. This point is a critical failure point. You must use a separate clean applicator stick to mix the blood into each drop of anti-sera to completely prevent cross-contamination. Once mixed, you physically tilt the slide gently back and forth for about 2 minutes. This constant motion forces the cells and antibodies to interact. It produces an easily observable reaction. Look at this comparison to read the result. A negative reaction remains a smooth, uniform mixture, but if you see a macroscopic agglutination, the heavy clumping on the right, that indicates a positive reaction for that specific antigen. Identifying this preliminary blood type immediately helps the blood center triage its inventory, ensuring the accurate labeling and routing before the blood even leaves the donor room.
We now proceed to the blood collection procedure. Proper laboratory practice and strict biosafety are paramount in this step. Proper hand hygiene is performed before and after donor contact.
Once the donor is cleared, you need to stage your workstation. Ensure you have the primary blood bag containing CPDA1 anticoagulant and the necessary pilot tubes ready for immediate access. Following this exact sequence guarantees you will produce a cross-match ready blood unit for the laboratory while keeping the donor comfortable, safe, and willing to volunteer again. Step 1 at the donor chair is to apply a blood pressure cuff inflated to between 40 and 60 milliliters of mercury. This specific pressure distends the veins to make them visible without cutting off circulation. This diagram shows the anatomy of the antecubital area. Your target is the median cubital vein located centrally between the cephalic and basilic veins. It provides a large, firm site for the draw. Clean the targeted site using a 0.75% iodophore swab. Start at the intended puncture point and move outward in a concentric spiral until you have scrubbed a 3-inch diameter. Let the iodine air dry for a full 30 seconds. Do not wipe it or blow on it. This full exposure time is required to achieve minimum bacteriostatic action of the skin. Once the site is clean, repalpating the vein is strictly forbidden. Touching the site, again, pushes surface bacteria directly into the puncture path. If collected into the bag, those bacteria can multiply during storage and cause fatal transfusion-associated sepsis in the recipient. For the venipuncture, you must use a sterile 16-gauge needle. A 16-gauge needle has a wide lumen. If you attempt to draw a full unit of whole blood through a smaller 23-gauge needle, the sheer mechanical pressure will rupture the red blood cells. This hemolysis will destroy the sample. Insert the needle and carefully route your tubing so the blood flows freely downward into the primary bag, mixing directly with the CPDA1 anticoagulant. This table outlines the standard parameters for whole blood collections. Looking at the routine blood collection row, you can see the target volume is tightly restricted between 450 and 550 milliliters. Because we monitor the draw using an electronic scale, you must track the physical weight. As shown in the weight column, a standard 500 milliliter collection must weigh between 474 and 579 grams to trigger the clamp. While the bag fills, gently mix the blood with the anticoagulant every 4 to 5 seconds to maintain an even distribution. Using the large gauge needle protects the cells from physical destruction, and hitting the precise volume targets ensures the ratio of blood to anticoagulant is correct. This prevents the unit from clotting and preserves it for a patient. As the primary collection finishes, use the inline sampling port to fill your pilot tubes before you remove the needle. You need an EDTA lavender tube and a red non-additive tube for the laboratory. Apply unique identification barcodes to the primary bag and the satellite bags and pilot tubes while standing at the donor side. Withdraw the needle in one smooth motion and immediately engage the plastic safety shield securely over the sharp needle tip. Discard the shielded needle straight into a yellow biohazard container, then instruct the donor to apply firm pressure to the puncture site using a sterile gauze.
The final step is post-donation care.
Before the donor leaves, provide their post-care rules. They need to rest, drink extra fluids for the next 4 hours, and avoid strenuous activities for the remainder of the day. You must also monitor for adverse reactions. If a donor experiences vasovagal syncope, meaning they feel faint, have them lie down, elevate their legs, and apply a cold compress. If a hematoma forms at the site, apply a firm direct pressure and an ice pack. Completing the labeling at the bedside secures the chain of custody for the laboratory, and identifying physical reactions quickly ensures the donor recovers without complications. Back at the empty workstation, dispose of all remaining blood-contaminated materials and glassware directly into a proper sharps container. Decontaminate the workstation surface thoroughly with an approved clinical disinfectant to completely eliminate the hidden risk of blood-borne pathogen transmission.
Thank you for watching the step-by-step demonstration of the donor screening and blood collection procedure.